We will now demonstrate a safe and effective method of cervical spine manipulation with the primary goal of improving side bending. There is often hesitation by practitioners in using manipulation for the cervical spine due to the unfair attention given to adverse reactions and the close proximity of arteries to the area of application. This often scares younger practitioners from mastering the techniques, and patients miss out on a tool that is powerful in therapeutic benefits and fast at improving symptoms. The reality is, out of the three main regions of the spine, the cervicals have less tissue protection from poor force application. Even still, given the correct application, it may be a safe and effective therapeutic approach to cervical spine dysfunction. Once you have decided that the patient warrants the use of manipulative technique, understanding the mechanics will allow you to apply forces that are precise and effective. This demonstration will mainly deal with the side bending component of a cervical spine segmental dysfunction. Before you perform an adjustment, you need to test and figure out what it is that you will be adjusting. You can use segmental motion tests that should have been a part of your training. Similar to the lumbar spine, C3 to 7 has facet surface contact that orients them towards side bending and rotation to the same side, with flexion and extension being key components as well. Determine what the position of the segment is, where the segment is made up of two vertebrae. The upper vertebrae will flex or extend and side bend and rotate to the same side. This will guide you as to the barriers you need your adjustment to address. Once you have a position of the segment and the barriers you need to engage, it's time to set up your adjustment. Remember, safety and accuracy are your primary concerns. In this case, let's assume the position or lesion of the C5-6 segment is flexed, side bent right, rotated right. So the barriers I need to engage at that segment are extension, side bending to the left, and rotation towards the left, with my primary contact being on the lamina of the C5 vertebrae. You can think of this as closing the left C5-6 facet joint. This 5-step process will help you achieve the basics of a safe and accurate cervical spine C3 to 7 manipulation with side bending as your primary component. Step 1. Position the treatment bed at your mid-thigh level. It may be slightly different depending on your body makeup. Lay the patient down on their back with their head resting in a neutral position and a pillow under their neck and head. Seeing as the segment is in the side bent right position, we want to move it into left side bending. We will stand behind the patient's head with our feet about shoulder width apart. We take our left index finger and place the lateral MCP joint of that finger on the left lamina of the C5 vertebrae. Our thenar of the same hand will sit at the top of the TMJ with our thumb resting on the jawline. This is our applicator. As a counterbalance to our applicator, our right hand cups the other side of the head with our thumb and index finger wrapped over the right ear. Step 2. It's now time to line up your forces to achieve a precise and safe adjustment. First, take the entire cervical spine into about 15 degrees of general flexion. This ensures that any extension performed is precise and segmental. For safety reasons, we want to avoid general extension on the cervical spine. Now that you have moved the area into general flexion, extend the C5-6 segment to its barrier. Next, engage the side bending barrier by folding the C5 vertebral lamina over your index finger until you feel a barrier endpoint. At this point, you should be moving your feet to better align your body with the direction of force you wish to achieve. This will mean that your right foot will become your back foot in a split stance position. Introduce some right rotation to bind up the tissues, but this should be minimal and done until you feel a tissue bind. Step 3. Understanding the direction of your force is key in making sure you achieve true side bending rather than rotation. Use these as general line of force placement guidelines for side bending in the cervicals. C7 is just above the opposite nipple of the patient. C6 is at the lower crease of their opposite armpit. C5 is at the upper crease of their armpit. C4 is at the anterior deltoid of the opposite shoulder, and C3 is at the apex of that same shoulder. Your force should be applied in a direct line, not in a rotary fashion. Your direction of force should line up your elbow, thumb line, and force placement in a straight line. Your preload should follow the same line. Step 4. Preload in the cervical spine follows a less is more mantra. If you excessively preload, there is every likelihood that the patient will stiffen up and guard against your adjustment. This will also leave you with no room to go with your thrust. So your guiding principle should be the ease of the patient. If they feel tense, then you have used too much preload on the tissues. You want just enough preload to help bind up the tissues and not too much so that the patient tenses. Preload the sidebending vector by pointing your left thumb in the direction that you want your thrust to go. In this case, we want our thumb pointing towards the upper crease of the armpit. You want to gently load that direction whilst counterbalancing with your right hand. Step 5. When you feel enough tissue bind without the patient tensing, it's time to apply your thrust. Aim your thrust in the line of direction that we have just set up and follow that in a straight line for proper side bending. Do not let rotation along the jawline creep into your force application. This error will turn it into a rotation adjustment towards the lesion. For adjustment of the left C5-6 facet joint, apply enough force to reach the clavicular area, and then come off the adjustment quickly to achieve minimal recoil. Your force primarily comes from contraction of your pectorals, triceps, and biceps. Be careful to apply a correct counterforce from your opposing right hand on the patient's head. Do not be timid with your force. Apply a short, sharp, and fast force that will achieve the desired effect. An audible cavitation here is highly desirable. If no cavitation is heard, retest your segment to see if you have made improvements in range of motion. The practical application of preload and thrust is a continuum. We are describing it here in steps, but in real-world clinical application, the preload melts into a fast, clean thrust. It's now time to retest to see if you have made changes to the segment based on the testing you performed prior to your adjustment. Retest the same motion test that you performed before the adjustment to check if you are happy with the change in range of motion. The failure of this technique can be largely attributed to line of force deviations and being too timid with your force application. The achievement of the desired change after a retest would indicate a successful adjustment. Now it's time to apply these steps in the clinic and refine your technique.